Today we're going to be taking a look at celiac disease as part of the gastroenterology series. To start off, we can define celiac disease as an autoimmune condition which occurs in response to the ingestion of gluten. And gluten is this protein substance found in different types of foods, including wheat, barley, and oats. When patients with celiac disease eat gluten, it triggers inflammation of the small intestine, and more specifically the duodenum and proximal jejunum layers of the small intestine, and this results in the symptoms of the condition. If we go to the start of this process, gluten is first converted by the stomach into a substance known as gliadin, and it's actually this gliadin which is responsible for most of the pathophysiology of celiac disease. These gliadin molecules are transferred to the small intestine, and the small intestine is formed of different villi structures where the remainder of the pathophysiology takes place. Now, in healthy individuals, gliadin should not typically pass across the villi structures, and this is made possible because of the tight junctions between the cells. These tight junctions prevent gliadin from entering into the lamina propria, which is the layer beneath the villi themselves. What happens in celiac disease is that the tight junctions are not as compact as usual, and as a consequence, the gliadin molecules end up diffusing across and entering the lamina propria layer. If we expand on this layer, we can see what happens once gliadin enters. In the first step of this process, gliadin is converted into a substance known as deaminated gliadin, and this reaction is catalyzed by an enzyme known as tissue transglutaminase, or TTG for short. The second part of this process involves macrophages, and these macrophages basically help to filter different molecules which arrive via the gut. The molecules which are entering are engulfed by the macrophages, which then process them and display specific antigens on their surface to determine whether the molecule is safe for the immune system or whether there's a potential for harm. A key determinant of which molecules will be displayed by macrophages is the major histocompatibility complex, or the MHC class, which I've colored in grey here. These MHC groups will basically decide which molecules need to be displayed to the immune system and which ones don't, and this is coded for by the HLA genes. In particular, there can be examples where the MHC group is coded for by a different type of gene which makes the macrophages slightly dysfunctional. And examples of this could be the HLA-DQ2 or HLA-DQ8 mutations, which basically result in the macrophages being less self-tolerant compared to usual. This means that the macrophages might present molecules on their surface which would not be presented in normal individuals. These two HLA mutations are heavily associated with celiac disease, and we can return to our main diagram to see how this might affect the pathophysiology. Because these macrophages have these dysfunctional MHC groups, which are colored in red here, they end up displaying the deaminated gliadin molecules from the previous step onto their surface, even though in normal individuals this would not typically be presented. As a consequence, CD4 T helper cells end up arriving on the scene, and they bind to this molecule, eventually triggering an immune reaction because of the deaminated gliadin. This subsequently activates both B cells as well as cytotoxic T cells, which end up damaging the small intestinal mucosa. The B cells activate plasma cells which secrete antibodies against different parts of the gliadin pathway. So for example, we get anti-gliadin antibodies which target gliadin directly, as well as anti-TTG antibodies which target the enzyme. There are also anti-endomysial antibodies which attack the smooth muscle of the small intestine. As well as this, the cytotoxic T cells end up damaging the enterocytes directly by releasing perforin enzymes. If we put all of this together, you can see how the combination of the cytotoxic T cells and the production of the antibodies leads to inflammation and damage to the enterocytes over time. As a result of this damage, the villi lose their normal functional capabilities, and they can't absorb other molecules such as iron, vitamins, calcium, and fats as well as they normally would. This malabsorption is what leads to the signs and symptoms of celiac disease. Patients often report gastrointestinal symptoms, which can include abdominal pain and bloating, nausea and vomiting, and changes to the stool, so for example, diarrhea or steatorrhea, which occur due to lack of fat absorption. As well as this, there might also be some deficiency symptoms, so for example, shortness of breath and fatigue due to iron deficiency, peripheral neuropathy or ataxia due to vitamin B12 deficiency, or bone pain due to vitamin D deficiency. There can also be some other symptoms of the condition, so for example, amenorrhea in females, or specific skin conditions such as dermatitis herpetiformis, which basically occurs due to the level of circulating autoantibodies in the blood. In terms of the cause of celiac disease, the exact primary driver is still unclear, but there are some risk factors which can increase the likelihood of the condition. For instance, if there's a strong family history where at least one first-degree relative is affected, it can increase the probability of the condition to up to 10%. In addition to this, there does appear to be a genetic element too, where we have the HLA-DQ2 and HLA-DQ8 versions of the genes, which are associated more heavily with celiac disease. There does also appear to be a link with other conditions, such as type 1 diabetes and Down syndrome, where individuals who have these conditions are more predisposed to having celiac disease as well. Finally, there can be some environmental factors as well, including early rotavirus exposure, or if gluten is introduced into the diet too quickly, at an age of less than 6 months. For the investigations of celiac disease, this involves serology testing and endoscopy to confirm the diagnosis. It's important that patients should continue eating gluten during the testing phase, as this helps to reduce the likelihood of false negative results. If we take a look at serology testing first, we can measure the levels of autoantibodies in the blood, which can include IgA-TTG antibody and IgA anti-endomysial antibody. It's also important to measure the total IgA level, as an IgA deficiency could potentially mask the serology findings. Turning towards endoscopy, this involves inserting a flexible tube into the duodenum, where biopsies can be taken at different locations. The key findings to be aware of on biopsy are villus atrophy, crypt hyperplasia, and lymphocytic infiltration, which are seen in most celiac patients. Just to illustrate this, we have a comparison between the normal villi on the left and the villi seen in celiac disease, where we can appreciate these features in more detail. In terms of the management of celiac disease, this involves adhering to a strict gluten-free diet, because it's inevitably the gluten which is instigating the autoimmune reaction. If we therefore remove gluten from the diet of these patients, it results in decreased inflammation around the small intestine, and the villi gradually heal over time. It's worth noting that flare-ups can still occur if gluten is ingested after the period of adherence, so the management of celiac disease is often lifelong. To finish off, we have a summary slide here which outlines the key points from this session. I hope you found this video helpful, and I'll see you in the next one.